If you finished the last session feeling a little despondent about the state of the world and healthcare in America more generally, I'd like to give a quote to get Bob started. And he can perhaps fill in who this quote comes from. We spend more than $630 billion more on healthcare than expected based on our wealth, which is more than enough resources to ensure that all Americans are able to receive world-class healthcare. By reducing the unnecessary variation in the system and enacting economic incentives that are more aligned with patient outcomes, we can dramatically improve the productivity, performance, and affordability of our health system. That sounds like a quote that comes from a McKinsey man. In my view. I'll let him take it from here.
Thanks, Ray. It's exciting to know that people read reports that I write at McKinsey. And it's also scary to realize how naive they are because you write them before you go into government and you do some math and you say, we spend about $630 billion more than we need to. If we just redirect a little bit of that, we could cover everybody. And this will be fixed, and we'd have a bunch of money left for deficit reduction. And so you write reports about that. You go tell, campaign people about it. You feel very smart, and then you get asked to go into government and do it. And then you realize that you might be able to cut $50 billion a year, which is what actually we cut a year out of Medicare. It's $500 billion over 10. It's $50 billion a year, not 630. And then you're told that you've actually, devastated the program and then there's allegations that I'm a death panelist or a rationer in chief, and my mom calls me and says, what are you doing? Go back to McKinsey. And so now I have. It is also gratifying that when there's no press in the room to hear two Republicans basically agree and take credit for all the reforms that we put forward, which is also something that I wish the record could show. The individual mandate is now a Tom Scully invention. It's fantastic to hear that. The exchanges, of course, was a Scully investment. Mark McClellan is the father of payment reform, accountable care organizations, the PGP demo, all the quality ratings. So it is great to know that the Republicans are taking good credit for the excellent policy ideas that they've been putting forward for years. I had the privilege of getting to put them forward. The thunderstorm you heard was what it was like to be at the White House during August. We cost the president the House. I think we cost him a desire to ever do healthcare again. I'm confident that we've delayed future reforms for a long time, as Mark and Tom have said. I'm going to speculate about how long, but 2013 strikes me as sooner than the public wants to have a big debate on healthcare reform. So I'll take a few minutes and walk through the future of Medicare. I think one of the themes that will come out of my talk and what you've heard from Tom and Mark is that the policy ideas are actually shared, similar, and no matter who's in charge, President Trump or President Palin or whomever might come, Vice President Sheen, you never know. When you open the book of policy ideas coming out of the best think tanks in Washington, there's not many choices. So I'll lay out what they are, and I think we can predict how the world will evolve. What's uncertain is the timing, but I think what is certain is we're going to get a lot more productivity in the healthcare sector. So with that, three things I'll talk about. I'm going to talk about the tsunami of debt coming, but since we've heard about it twice before, I don't need to further depress you too much. I'll talk a bit about the premise of the Affordable Care Act and what's happening. A lot is happening, and I think perhaps some good will come out of that might make the future better economically than it is today. I think it's certainly going to be better for patients because of a lot of data transparency and efforts to improve quality and reduce variation, which I'll get to. And then I'll talk about what happens next if those things aren't enough, which is what I think will be most interesting to you all since you know a lot about the first two. So this is a chart that's colorful, which is, the more you look at it, the worse it looks. That shows you healthcare spending. The US is the dotted line. The rest of the developed world is the shaded colors. The bottom is basically 0 to 25 percentiles, and the top is sort of Germany and France. Every part of the world that's developed has healthcare spending growing faster than their economies. So you all wish you were China and India, where that's not true, or Brazil, or Russia right now. But every developed economy has the problem of healthcare growing faster than their economies. The OECD, which we wish we were in some sense, grows at 2% faster than GDP, so that's unsustainable. And we grow at 2.5%. The CBO, love or hate their math, posits that healthcare reform will reduce our healthcare inflation from GDP plus 2.5 to GDP plus 2.25. or GDP plus 2, and that's called bending the cost curve, and that is trillions of dollars of savings, and pushes out our fiscal disaster for beyond our lifetime. That said, more will have to be done, because that's clearly not enough, because the economy will not grow faster than healthcare. And so you still have the problem of you have to bring this in line over time. But it's not going to come down in sort of a single structural. It will have to be more, it grows slower, the economy grows faster, and eventually these things actually meet a long way out in the future, sort of the premise of everybody's healthcare reform plan, no matter who they are or where they come from. We calculated, and Ray, this is the report that Ray quotes, that the US, when you calculate and adjust for wealth and purchasing power parity, we spend about $700 billion, now $900 billion a year, more than you'd expect based upon the wealth of our country. So that's theoretically money you should be able to capture through productivity, but from a policy perspective is totally impossible to capture. But that's the hope, is that there's about 30% of the money, no matter who you look at, whether it's the great work that Sherry Lee did at Columbia here, or the IOM work, or work we've done, or Dartmouth have done, everybody says about 20 to 30% of the money ought to be able to be redirected. And the premise of reform is much of it's redirected to pay for coverage expansion. This is the long-term outlook. The dark line's the revenue line, which is why taxes will unfortunately go up, or we call them fees now in the Democratic Party. Fees will go up. Because fees are less than expenses. And Medicare and Medicaid is the thing that's growing the fastest. Social Security, interestingly, is intellectually an easier problem to solve, but it's unfortunately solving it doesn't solve the problem, and so you have to tackle Medicare and Medicaid. And the issue really is what scenario you believe. So Tom made a comment that I'm going to now say isn't exactly right, but it's sort of right, that we're at historical levels of GDP, as debt as a percentage of GDP. We're at about 12% right now. It was much, much higher around World War I and World War II during. But you can see that the scenarios that the CBO forecasts out makes it look, devastatingly disastrous, or the extended baseline scenario looks kind of okay. I mean, not really, but there's a lot of uncertainty about how fast the economy is going to bounce back. What will be our GDP growth? What will be revenues? Obviously, revenues fall during the recession, but what will be the rate at which they bounce back? Tax reforms to sort of lowering and balancing the tax base to broaden it will be probably something that comes after the 2012 election, which will bring in more revenues. But which baseline scenario we're on will really predicate how fast we have to tackle the problem. Where the problem is most acute, and you sit in New York, so you're really attuned to this, is at the state level. Since states have to balance their budgets, they don't have the luxury of playing with baselines and 75-year budget windows. They have to do it each year. And so states are having a real problem, which is $126 billion they have to cut out of their budgets this year in the country. The stimulus money that they got, which was quite a bit from Medicaid, ends in June. And so you're going to see tremendous responses, in the summer and in the fall for states to help take money out of their budgets. And Medicaid is unfortunately, for those of you in the health sector, in most states the largest budget item in their budgets. Medicaid and education are roughly equal in many states, and then transportation and prisons is the rest. They're all unpopular to cut, and Medicaid's the one that's growing fastest. Long-term care in particular is a big problem. Prescription drugs is a big problem for states because they're both growing quite a bit faster even than hospital services. So states are going to have to take much bolder action more quickly. As Tom Scully said, many of them are looking at managed care as an option because managed care, at least you can lock in a price and a growth rate over several years. Most of them can do managed care contracting in a wiser way in which they get the high-cost populations into management. Managed care plans can do things that state legislatures won't let you do, like managed care, like managed formularies, like create incentives for patients. And so you're going to see a lot of growth in that area. You're also going to see provider cuts that are deep and painful, because that's the fastest thing states can do, although that's not, as Mark McClellan said, you can't sort of cut your way in provider rates out of the problem, because utilization does go up when you do that every time. So what did the Affordable Care Act do? It was designed to do three things, and we can debate and give grades on how well it does each one of them. After Tom's talk, there's now more uncertainty in my mind about the coverage expansion, but I'd be surprised if it's delayed. That said, I mean, if it were, it would undermine the ability which it extends access. But the uninsured problem is the one that Republican or Democrat politically has to get addressed. So today we have about 50 million Americans who are uninsured. That's going to be 60 million Americans in 2014. And if you believe anything about economics and price elasticity, it's going to be quite a bit higher because it's crowding out too much wages, and firms and workers will choose not to get all their wages in healthcare, and they're going to see more people actually opting out of coverage. On costs, I've said we spend more, way more than you'd expect. We spend more in healthcare each year in this country than the entire Chinese domestic economy consumes. So it's massively too big. And on quality, this was the least, my job in the White House was to work on delivery system reform and improving quality. Both were particularly unpopular, but on quality, we do far worse than you'd think. And the question that came earlier about how do you find a good doctor, I mean, I call Emmy DeLand or somebody at NYP and ask her, who should I go to? And I pray that she's right, but there's no way to know right. There's no way to know quality, and variation's far too great. And so you kind of have to go by trust and instinct, and people like me as a doctor because I had a nice bedside manner, but God knows if I was any good. And I remember the first time I got a report card back from Tufts Health Plan, which said I was solidly average. My initial reaction was that the data was wrong. So I called them up and explained that the data was wrong. Then they walked me through the data, which actually was right. And then I said, but I didn't know I was actually the primary care doctor. I thought I was just a consultant offering opinions. And so then suddenly your behavior changes when you realize that you're the one who's supposed to do the mammogram. Mark's comment about who's the diabetic doctor. Well, there was a lot of examples like that in my patient panel where I didn't know I was the primary doctor for that condition. And that kind of unintentional poor quality and lack of systems of care leads to tremendous variation in outcomes and extra costs that we ought to be able to tackle. And there's a big data problem that we're trying to tackle in healthcare reform. So what does healthcare do? It has coverage, it has subsidies, it has a mandate, it has exchanges. On the cost side, it cuts very little and it spends very little, actually. So we spend $2.7 trillion a year. This is about $100 billion of spending a year, of which $50 billion is redirected. So it's a small amount of new spending in actual real terms. As a result, the cost cuts are relatively modest as well, as we've heard from Tom's presentation. There is some big opportunities. Most of you will be surprised to know that a hospital has a half a FTE per bed to do revenue cycle coding, collections, and just all the billing processes. It costs $7.50 for each hospital bill to be actually billed, which is about $7.48 more than Visa charges to do a transaction. There's a lot of payment inaccuracy. So if you listen to the president talk, we talked about fraud, waste, and abuse. It's much more payment inaccuracy. So if you've ever gotten a hospital bill, there's a 100% chance that it's actually not correct in terms of the coding of the bill. The errors are in both directions. So there's overpayments, underpayments. Net, it probably, in aggregate, the payments are about right. But there's just a tremendous amount of waste in the payment systems itself, and it's kind of inaccuracy. And there's a huge opportunity to pay differently. So if you ask me what's the biggest thing we need to do to change the bend the cost curve down, it's change how we pay. By paying fee-for-service for activity, you get more activity. In the hospital, we do it better than the outpatient sides. When the hospital will often pay for an entire course of care in the form of a DRG. On the outpatient side, though, it's a total fiasco. We pay for every single thing the doctor does. So what do we do every year? We do more stuff. And even worse, the margins are very skewed because they're based upon ill-defined cost models that kind of misproportion how much labor goes into them. So you make all the money on the testing. So if I see you, I get paid $50, $60 for seeing you. I'll make $50 or $60 for the X-ray that I do, make $250 for the MRI or the CT scan, and make quite a bit from the phlebotomy fee in the lab on the outpatient side. So you make all your money from all the stuff that actually isn't really the patient care part. And Medicare pays for it, and most commercial insurance companies pay for that. So the money's actually on this outpatient diagnostics and procedures and technical things, as opposed to achieving clinical outcomes. So that leads to a lot more activity in the US than you'd expect, and not surprisingly, a lot of extra cost. The premise of ACOs and of bundled payments is to help Medicare hopefully catch up with what I hope are successful efforts by private payers to begin paying for different units of care, and ideally, trying to buy an outcome. We want to buy a year worth of hemoglobin A1Cs of less than 8, in the future perhaps. On quality, there's a big emphasis around data, around some penalties around poor performance, as well as a lot more flexibility for Medicare to implement programs that are cost neutral or better and quality neutral or better. So Medicare can now scale many things that Congress would have stopped as a result of having the Innovation Center. So the CBO score is all important. The first thing I'll say is it's wrong for sure. We don't know which direction, but it's probably plus or minus $500 billion if you were to draw the error bars. The Part D benefit that Mark talked about, that Tom Scully thought about, Mark implemented, and then we benefited from, cost $340 billion less than CBO predicted. The Balanced Budget Act of 1997, which we're going to have again someday, saved a lot more than they expected as well. But CBO scoring, if you look broader, it's a scatter plot. And they're wrong in each direction actually equally often. There's not a strong correlation. Most people say that they're conservative, but actually data says that they're actually just wrong in both directions. You don't know which way. So they say healthcare reform saves $120 billion, now $230 billion. That's important because to repeal the law, you have to find $230 billion of new taxes or new cuts. And as you've just heard from Mark and from Tom and from I, there's not a lot of easy things to cut, although we didn't cut that much. Politically, you walk outside or you look what happens at Paul Ryan's meetings now over the Easter recess. People aren't excited about any more cuts. And taxes, I mean, you looked at Tom Scully's slide, and there's not a lot of room to go up on taxes, and that obviously is not a popular policy either. So it's very hard to repeal this law. It's also very hard to get anything through the Senate. So Tom showed the prediction, which is I tend to think is right. The Senate will probably be 53 Republicans, 47 Democrats in 2012. You need 60 votes to do anything in the Senate. So I, as a naive, first-time into policy person coming to the White House, thought, great, I'm at the White House, we're in charge. We're not in charge of much. The House can do whatever it wants. The White House can talk a lot and pray. But the Senate's Finance Committee is in charge of actually all laws in the country. You have to get at least one Republican or one Democrat, one minority party person to vote something out of committee there. And then you have to get 60 votes in the Senate to basically get anything to move. And having 53-47 means almost nothing's going to happen. And it'd be very hard to make sort of big changes. Now, maybe as part of a very big, very popular deficit reduction bill of 20-something, you could see that happen, but it's very hard to coalesce things, which is why also narrow provisions, whether it's the IPAB or the Innovation Center or other things, won't go away because you can't align 60 people around a small thing because of the political cost of it. And 60 votes is what you have to have. We had 60 votes and still couldn't do it, those of you that watched. Then Scott Brown came in, and then we had to figure out how to get creative. But it's incredibly hard to change stuff through the Senate. And so this score makes this bill almost intractably hard to take away because it's Solomonic in terms of it saves $120 billion, now $230. You have to find that as a new offset. Very, very, very hard to find it. The other point that I put on the bottom is that the CBO in the same model does say that, particularly in the out years, this saves trillions because it does slow the rate at which medical cost grows faster than the economy by 25 to 50 basis points. But it still grows faster than the economy in perpetuity in their score, and probably as a result of this legislation. This legislation phased in over forever, not only because we wanted it to be phased in forever, but because it takes a long time to actually do it. There's a bunch of things that are cumbersome about this, including 50 state exchanges as opposed to a federal one that takes a lot of time to design and regulate. One of the things that, if you looked at Mark's slides, the revenues and the offsets balance each year. And so you'll see that they kind of start, but they roll and they compound over time. The quote popular stuff was done first. It wasn't quite as popular as I think we were hoping. The tanning tax, which was one of my singular contributions to this, also came in, which is a public health miracle, but also hasn't received the positive attention that I would have expected. And then in 2014 is when then in theory, the coverage expansion begins. 2018 is when this important Cadillac tax comes. This is a policy that's a good policy, although it had to be artfully designed. This is the McCain tax exclusion, basically. But because we couldn't call it the McCain tax exclusion, we had to call it an excise tax on high-cost health plans that's indexed so over time it will have hopefully the same effect as actually taxing health benefits. But in the short term is, an excise tax on high-cost plans. In 40 years, when this is affecting most Americans, this should lead towards, price sensitivity on the generosity of health plans and a preference not to have health care be a preferred form of compensation for high-wage people. It's a premise. Healthcare reform plays out very differently across the country. And so while it's true, there's in macro terms winners and losers. And in aggregate, when we were thinking about the different fees, as we call them, to sectors, it was designed to sort of take away windfalls, but not sort of allow for major disruptions. When you play it out at the county level or at an MSA level, you get lots of unevenness. If you take New York State, what you see is in Manhattan, There's a high number of people that will be covered because there's more uninsured, there's more low-income Medicaid people here, but in other parts of New York, there's much less movement and things. And so this is going to play out very differently, which is why when you talk to hospitals, you'll get very different perspectives on how good or bad this is based upon where exactly this is in the market. The other thing that's very important to note is that, and this came up in Tom's talk as well, is that the switching costs of insurance have gone down a lot. So if you try to buy insurance today, you undoubtedly are frustrated by the experience. You might, if you're a small business, use a broker who charges you a lot and doesn't bring you many rates, and they're all much more expensive than you expect. And once you have it, it was so arduous, you don't really want to switch. These exchanges make it a lot easier to switch. In Massachusetts, one of the lessons, there's lots of interesting lessons from both Utah and Massachusetts, is that by buying on a website where things are all displayed in a fairly like way and the prices are sort of transparent and they show you net of subsidy what you pay, you can switch a lot easier. So that creates a lot more churn in the books of insurance companies, which terrifies an insurance company, because the way you make money today as an insurance company is price correctly. So underwrite people, charge them more than their medical expenses because you have good modeling to figure it out, and then keep them a long time, the ones who are popular, and reprice the ones who aren't so they churn out of your book. In 2014, not only do we create exchanges where you can shop more easily, but also the rating rules change radically. So in 2014, you have to do guaranteed issue, which means anybody who wants to buy a coverage from you has to be able to buy it. There's community rating, so you can't underwrite based upon a person's actual predictable medical costs. You can only underwrite based upon age, can't underwrite based upon sex, and on smoking status. Even more complicating is the fact that your premium variation can only be 3 to 1 from the highest cost age group to the lowest. And so those are your constraints. You also have to have some basic attributes like free preventative care, no annual limits. You can't rescind the policy mid-year like happens occasionally today. So that makes it very hard to know how to price. And people can switch much more easily in these exchanges. And so that creates a market where they have to think more like a mobile phone company where they're trying to retain the profitable members and turn out the bad ones than insurance companies today where you basically try to price right. And so that's a major, major change. And in our modeling and everybody's modeling, there's a bunch of simulation models of this, what you see is that this exchange market becomes fairly large. You see a lot of churn between Medicaid and the exchange market because it's 133% of federal poverty is an income level where people bounce above and below it a lot. So as of 30% of people are likely to actually churn between them. That's something that does worry me as a clinician, in that the Medicaid network of doctors, particularly on the outpatient side and those in the commercial plans, are quite different. So if you have a patient with diabetes or asthma, the Medicaid provider and the commercial insurance providers are unlikely to be the same. And so it's going to be hard to have continuity. So one of the worries of this. But there'll be a lot of volatility between those two. In the individual market, there'll be a lot more churn as people make different choices every year or enter and exit the market as they gain or lose employer-sponsored insurance. There'll be some small employers who choose to go into the exchanges. Firms up to 50 and then going to 150 can go into the exchanges in the first few years. The exchanges are likely to have either lower broker loads or no brokers, and so if you're a small firm, you might actually like to go in because you'll get probably more choices and less load on the plan. So there'll be a lot of dynamism in the market that creates a lot of sort of volatility. So if you're a plan, you know exactly how many members you have today, and if you read the quarterly reports of any of the commercial health plans, there's remarkable stability in the number of members. It's unlikely that will be as stable in 2014, and we predict that there'll be a lot of moving and shopping. So what do payers do to position themselves besides have lots of angst and worry and uncertainty about how to price? They're trying to figure out how to gain benefits in their medical cost management. So most of the cost of your health insurance is actually, most of the money is consumed by others in the health plan who are spending the money. And little differences in how efficiently the plans can manage the medical cost risk make huge differences in their performance. Every plan, bar none, and I've spoken at lots of healthcare meetings, met with lots of plans, every plan in the country is saying we have to get away from fee-for-service reimbursement as fast as we can. They have no idea what to do, though. So, there's a good agreement among Republicans, Democrats, health plan executives, hospital leaders, doctors. The fee-for-service leads to sort of irrational consumption, not perfect incentives, the stuff that you want doctors to do, they don't do. There's people that close their eyes and think about the paradise of capitation when it was done at least by Kaiser and Geisinger. But then you say, gosh, like, that can't be replicated in regular America because doctors are fragmented and hospitals are small and the patients are all going across networks. So what do you do in between? And you end up with hybrids like medical homes, accountable care organizations, bundled payments, 30-day post-acute bundles, guarantees, which are all basically smaller forms of risk sharing with providers designed to buy a bigger unit of service. And these are four, but I could list 400 examples of health plans who are trying to come up with different strategies to mitigate the rate at which costs grow and give more risk to providers and hopefully more upside for providers who manage that risk well. The largest experiment is done by Massachusetts, which is called the Alternative Quality Contract. Mark mentioned it in passing. 40% of doctors in hospitals in Massachusetts are now in this contract, which is a 5-year contract, where effectively you take current spending today, you grow it at CPI, and then there's upside if plans hit quality measures and save money, but there's risk in the out years for plans if they don't. It's basically how it works. United Healthcare and many others are working on accountable care organizations and bundling. So bundling is basically take an elective condition like a pregnancy, you pay for the whole 10 months of care from all the prenatal care, the hospitalization, and the post-hospital care. You give one lump payment to somebody, which is the hard part to figure out who to give it to, and then they manage it over the course of the condition. It works for elective surgeries. It works for things like pregnancy where you can sort of price it and predict it. It's hard to do for chronic diseases at units smaller than a year, and it's very hard to price it. There's a lot of buzz about things called patient-centered medical homes. There's a mixed track record on these. On the one hand, it makes sense. You pay the primary care doctor more money, and you say, now try to manage the downstream costs. The hard part is you put a lot more labor into those practices, and you don't necessarily get a lot of cost savings. But that they plus accountable care organizations hold some promise to create managed networks where people aren't all employed together, but they work together, and they have some motivation around sharing some savings. The other thing you're seeing is hospitals approaching, or payers approaching hospitals saying, we want guarantees or warranties on your care. So we'll pay you a little extra, but if there's complications or readmissions, we don't want to pay for those. So you're seeing some interesting experiments. None of these are at scale, and the reason they're so hard to scale, and the reason why these are all demonstrations and experiments is that it's incredibly imperfect how to measure undertreatment. And we're terrified in healthcare reform that Zeke Emanuel and I wanted nothing more than to go put in some other payment model that would hopefully have a bunch of quality measures and lead towards productivity. But we're terrified that there's going to be, the grandma somewhere where the doctor unethically didn't do something and something horrible happened. And it's easy to find those examples. It's hard to find the people that didn't spend $10,000 to testify. And so because of the imprecision about measuring quality, the lag in data, the fragmentation of the world in terms of being able to manage risk, these are all sort of stepwise changes towards something that looks a lot more like population-based payments in the future, I believe. These all have done the beneficial thing, though, of creating a lot of organization. And on the one hand, you can say it's, consolidation. And Zeke and Nancy Ann and I wrote a paper about this that got perhaps the most harsh comments of any paper I've ever written in the press, but about how we're organizing the health system. There's consolidation happening at plans, between hospitals and doctors, between doctors into bigger groups, which I believe is a good thing for coordinating care, for measuring care, and it creates the ability to pay based upon shared risk, which you can't do when you have a 2-doctor group in New Jersey, which is how much of the country is. These plans, given the choice, will favor doctors over hospitals. Mark made the comment that doctors can manage hospital utilization a lot more readily than hospitals can. And so when there are large doctor groups, they'd rather capitate or take risk with them, because the easiest way to save money today in American healthcare, if you're a doctor, is to not let patients go to the ER by opening up your office on nights and weekends. You can take care of a lot of stuff in your office. You see it happening in Medicare Advantage a lot in Florida and Texas and California, where doctors have risk. They have retail hours for their offices. They actually have car services to bring you in every day so you don't go to the ER. I mean, you see radically different styles of practice. Kaiser does this. They've just built one of the nicest sort of urgent care centers on the planet in Washington, D.C., designed to keep people out of the ERs in D.C. The second thing you do is you avoid elective use of hospital technology because it's very expensive. So you use fewer CAT scans and MRIs, and if you do use them, you probably use a tool like Castlight, which can show you prices in the market and direct people towards equal quality, lower cost settings. The final thing you do is you avoid readmissions. Readmissions are fascinating. About 20% of patients in Medicare are readmitted within 30 days for the same condition. You can cut that number almost to zero, but at least in half if you just do two things. One is see them within a week when they leave the hospital on the outpatient side, so that's not that hard to figure out. You schedule an appointment, they go in and they see a doctor. The second thing is drug adherence. So, and I'm notorious, like every other doctor in hospitals ever, when patients leave, you write out like 25 prescriptions and hand them to them and say, go fill them. You don't really know what they're taking at home. They get home, they have their home meds, they have these new meds, and they don't know what meds to take, and so they don't take the right ones, and they actually go back because they're actually untreated when they go home, or they have actually interacting medications that aren't right. So drug adherence is the second thing. You actually reconcile the medications, have them take one set, make it clear, see them in a week, and you can cut this in half. And so this is the kind of stuff that can be done. Now, there's lots of confounding variables that make it harder, and the hospital folks in the audience, will look at me and say, yes, but these two things make a big difference, and so there's some penalties coming in the law to hopefully motivate this kind of behavior. But if you're trying to save money as a doctor group, you can actually do this stuff. This is stuff that doctors can do. For hospitals, it's more of a mixed bag. So in aggregate, if you take the cuts coming to hospitals, if you take the reductions in the uninsured or uncompensated care, now everybody will have insurance, or most everybody will, and you take those in exchanges who now have new commercial insurance, which will pay higher prices, you get some upside. So you get some more utilization of people who hadn't been insured, who are now insured, who can get medical services they wouldn't have gotten before. You have people paying more than they pay today. Then you have some cuts. So you have the reimbursement rate, which is the productivity adjustment, which is that 1.1% that Mark talked about. Reductions in DSH, disproportionate share payments, which is some the uncompensated care subsidies hospitals are getting. You have this Cadillac tax coming. Then you have a Medicare wage index. So there's all kinds of chicanery that goes on around how you've set the geographic prices in Medicare, and there's an adjustment of that will save some money for Medicare, but also probably raise it in some certain spots at the expense of others. The net of that, in aggregate, is about zero. So hospitals, theoretically, we took away as much as they get. In any given market, though, it's certainly not zero. It varies a lot. And so, and you'll see huge swings within a city depending on where a hospital is situated for how these cuts net out. But in average, it's, plus or minus 100 basis points positive to 200 negative of margin. It's a lot more than that at any given hospital across the country, which is why you're going to see a fair amount of acquisitions and divestitures and portfolio changes among hospital companies. One of the things that is accelerated, we just read a paper about this in the New England Journal, is this huge trend towards hospitals employing doctors. And those of you that have been around in your healthcare careers for a few decades realize that in the 90s, there's this huge roll-up of hospitals and doctors employing each other and forming big groups and trying to control volume and build networks. And a ton of money was lost. So the only company that exists is one that Tom owns called US Oncology today, sort of is a relic of that era. All the other ones lost tons of money, and the hospitals basically overpaid when they bought the doctors, and they gave them back the practices for free and said, please go away. We can't afford you anymore. I guess the management eras have turned over enough that the new era of hospital managers is saying, let's employ the doctors again. So 52% of doctors are now employed by hospitals in the country. And on the one hand, you could say that's great. You're going to have coordination of care. There's seeing them within a week when they leave the hospital ought to be easier when you have a network of doctors. Your IT can be shared. There's a lot of benefits potentially to patients of this. There's a big fear, though, which is prices. So as hospitals gain more structural power, do they raise prices? I believe many hospitals are thinking about this as an option basically on payment reform, that if there is a bunch of risk coming into the model, they'll want to have outpatient networks that can help them manage that risk. And if there's a real desire to use lower cost settings, having some that you control is a good idea. And so if ACOs and things really take hold. On the other hand, if they don't, you perhaps can raise prices, which sort of is the other side of it. What is true today, though, is that they're losing money on this. When they employ a doctor, they overpay for the doctor for two reasons. One is that when you give me a salary, I'm less productive. I actually see fewer patients. And in a fee-for-service context, that's not good for the hospital. And hospitals are much less aggressive at collecting the copays and getting paid than the doctors are when it's their entire livelihood. And so there's less, in general, less effectiveness on the revenue cycle that makes this not a great play immediately for hospitals, but you're seeing a lot of it happening. And you've seen all the for-profit hospitals make big announcements in their analyst calls about how they're planning to hire, thousands of doctors. And I think doctors themselves coming out of medical school are also more receptive to the idea of having a salary and vacations in the summer and a schedule that's predictable. So their doctors are also perhaps easier to employ than the generation before. But this is the big trend, and one that sort of comes with sort of two sides of worry, I think. And so there's 5 big uncertainties, I think, that the ACA has amplified. It hasn't created them, but it is amplified about what will happen to the economics. So one is this consolidation integration. I can argue effectively that it's good for productivity, that you create scale, you should get synergies, you can take some labor out, you get better coordination, you'll get higher reliability products. Or it could be bad because you get market power and you raise prices. It's uncertain how this trend plays out. Second one is, how to link prices to value. Prices today are basically input set. And because Medicare does that, it's kind of reference for which all other prices are predicated, and that system is very imperfect and doesn't know how to reward value, as came up from some of the questions before. How fast we can move away from fee-for-service and whether or not the next payment system is better. So you can shift from fee-for-service to capitation, which is many people's idea. But if you set capitated rates at far, far higher than the cost, you don't get a cheaper health system, nor do you necessarily get downward price pressure. So how do you actually shift to a system where there creates downward pressure as there is in other economic sectors? Creating well-functioning insurance markets and exchanges. So whether or not there's, a Ryan plan in the exchanges, basically, it's subsidies to buy private insurance, which is, akin to a voucher with an essential benefit. So at least it's anchored to something, but it requires markets that create price competition. That's been very hard to create for multitudes of reasons, and since there's a bunch of economics professors, I'm not going to try to exhaustively describe them, but information asymmetry is one of the biggest ones. And how do you create markets where you can create competition around price and value that's effective competition? And the final thing is getting enough data out there. So there was a question that came up about how do you select a doctor? Well, you don't have any idea how to select a doctor because there's not enough data on how to do it. And we have to get to a system where there's much more liquidity of the data, so there's a chance to have shopping. There's a chance to have prices. There's a chance to compete on quality. And there has to be more unity between the public data sets and the private ones so you can create a more complete picture. I think there will be Yelp-like things that make it easier that are powered by both data and consumer surveys that will help. There's some neat companies, ZocDoc's one that's here that's doing an interesting job at helping people shop for doctors and putting pressure on doctors to have better service and not make you wait so long and have magazines that are more than a year old in their lobbies. That are going to make it better. You have to do a lot more here on the market side to have it happen. I mean, this has been something that every HHS secretary, literally, in the last 20 years has been pushing for, and this law pushes for too, which is more data into the market. One of the best benefits of this law that nobody notices yet is that in 2014, Medicare claims identifiable to the doctor, but not to the patient, made public, put in the public domain for people to use. And while you won't use them yourself, there'll be people that actually suck them in and make products and tools that are useful, that I think will help change the market. And certainly as a doctor know that I don't like being below, whatever the top quartile or decile is. And so they're going to create a lot more competition among providers about, improving performance. And there'll be a lot more flexibility to the market about how they define performance because data will be made available as opposed to sort of just aggregated measures, which should make the system work a lot better. So what's going to happen if this doesn't create utopia or nirvana? So plan A, basically, these are the 6 things in healthcare reform that are designed to change Medicare, to make Medicare economically more sustainable, better in terms of the system of care that it buys. And then there's the plan B. So the 6 things are ACOs is the biggest payment reform in the law. And you just heard about Mark, how it's an incremental step, but it's a step, I think, in the right direction. There's not enough upside, though, to drive a whole lot of providers into it because you could still make more money buying the CAT scanner than doing the shared savings. It's not quite set up in a way that economically you're going to want to double down unless you have private payers that are already paying you in that way, so you're actually aligning what you're doing. There's some penalties around readmissions and hospital-acquired conditions that are good that I think will help reduce or improve reliability and reduce rework. Bundled payments hasn't gotten any attention yet because it doesn't happen until 2015. The law requires that 5 conditions are bundled and that there'll be a lump sum payment for inpatient and outpatient care for 5 conditions. You should pray, as I am, that they choose 5 conditions that actually are meaningful when it comes to economic spending. And the longitudinal spans are long enough that you create a need for productivity. If you do ear tube bundling, it's not going to make a whole lot of difference. If you do a year of diabetes care, you could have a pretty profound effect. So we should hope that they pick good ones. There's a Center for Innovation, which basically allows scaling of things that are good ideas that are never scaled without going back to Congress. We should pray that they use the authority. As you can see, Don Berwick, despite having some good ideas, has a hard time using the authority because everything he does is subject to an angry hearing or a public meeting that's upsetting. There's a productivity adjustments for hospitals that will require hospitals to take out a fair amount of cost. I hope it actually leads to productivity. The 3 sectors in the economy where there's not been productivity historically are the Defense Department, education, and hospitals. Every other part of the American economy shows lots of year-on-year productivity. We have to get it in healthcare. I'm terrified that as part of the jobs recovery plan of this country, one of the ideas will be to put lots more high-cost fixed labor into the healthcare sector. We actually need not more high-cost labor, we need more productivity from the labor we have. And so the economists in the room, I'm sure, share this fear, but this is one of the most popular jobs programs. And then there's the Patient-Centered Outcomes Research Institute, which is really comparative effectiveness research. There's all kinds of constraints and limitations to how it can be done that makes it less good from an economic curve-bending perspective, but it hopefully will give rise to research that will allow people to better tailor treatments. And one of the things I hope it does is help us figure out how to improve systems to get patients to goal. One of the worst parts of our health system is the fact that people who are diagnosed are treated on medications only half the time are achieving their clinical outcomes that they're meant to be achieving. So if it's blood pressure, it's controlled blood pressure. If it's cholesterol, it's controlled LDLs. A lot of people are taking drugs at doses that aren't therapeutic. And as those of you who are physicians know, the toxicities of drugs are not necessarily dose related, so there's not harm in titrating up the doses, but we seldom do it. We just say, are you taking the med? We don't actually then adjust the med, which is a big problem in healthcare. This institute might be able to do some research that helps shine light on that problem. If those don't bend the cost curve down, there's this kind of belt and suspenders. The suspenders is the Independent Payment Advisory Board, which hopefully has the courage and the persistence legislatively to then put in MedPAC-style recommendations to help constrain costs. I think one of the benefits of the IPAB is that it's an annual process, because you all know when you do BBA 1997 style things or ACA 2010 kind of things, there's a lot of unintended consequences and responses in the market that you don't necessarily predict. So having an annual way to adjust policy is, I think, conceptually a good idea to the extent that they're implemented effectively and the data itself is measuring it effectively. If that doesn't work, there's three other things that will happen. There'll be a Balanced Budget Act of 1997 version 2.0. Whether it's in 2013 or 2016, I'm not sure. But there's no question that if Medicare keeps growing at the rates that it's growing, and our GDP growth of the economy is 2.5% less, which it probably will be, there will be market basket-style price controls like BBA 1997 coming again, I think. That's the easiest thing for Congress to do. CBO scores market basket cuts, so you know exactly how much you get. They give us 0 credit for population health, 0 credit for ACOs, 0 credit for IPAP. All the stuff that requires behavior change and incentive changes, the CBO doesn't score, and Congress will have to cut, so this is going to be the mechanism. If you don't do that, you'll likely do defined contribution, which is the Ryan plan. And if you don't do that, there'll be a bunch of people on the left saying, well, a public plan would have saved a hell of a lot of money. Why didn't we do that? And maybe Vermont will have done it and proven that true. Who knows? But there'll be definitely lots of interest in bringing it back, I predict, on the left as a alternative. All of these reforms, as different as I just made them sound, or maybe I didn't make them sound, but they actually have a lot in common, which is what I think you should remember. They all basically are going to drive integrative care of some flavor. So it doesn't mean you're going to go to a narrow network HMO or Geisinger is going to grow to 7% of the US market or something. Geisinger will probably still be in like the middle of Pennsylvania. But it drives towards systems of care that can basically take a patient, manage some risk, and deliver a consistent outcome. And that's the premise of both the Republican and Democratic plans, and every health policy idea from Elwood forward basically has been in this direction. They all imply either stated or unstated, a lot of labor productivity. It's not more doctors doing more visits in high-cost settings between 9 a.m. and 3 p.m. It's a lot more team-based care, lower-cost labor doing the care, remote care, self-care, a lot less labor. They're all paying differently and putting some risk onto the providers towards outcomes. They all imply massively more data to help consumers shop effectively. If you believe anything about end-of-life care, if you believe anything about consumer-directed health care for that matter, you believe that when you give consumers information about the care they're getting and sort of the cost benefits and some incentives around it, that they behave differently. And whether it's shared decision-making or end-of-life with more data, patients make different choices. And so it's much more data into the market. Also, for the market, it's changing the basis of competition to be not just about reputation, but around actual outcomes. And so it's changing the nature of competition to be more objective relative to just pure brand and impression. And then the final thing is, interestingly, whether it's the Ryan plan or the IPAB or BBA 1997, BBA 1997 was followed by BIPA in 3 years later, where they then gave back about 4% of the 12% that was cut. So there'll be annual adjustments to this, and these all are premised on the fact there'll be an annual process to actually refine this, because there's no chance that in a consensus-based political process you're going to get elegant policy that's exactly right, that unleashes exactly the right market forces and incentives, which is why you have to have an annual refinement and lots of hope that there's some independence, I think, too, and some good data. The last thing I'll say before I take some questions is I just talked a lot about the health system and delivery, and can talk for another 5 hours on that. But if we really don't get serious about obesity, none of that stuff's going to matter, because morbidity of disease is going to actually far outpace our rate at which we can get productivity. And so I'm a little worried that that hasn't come up yet from Mark and Tom, because I know they agree and I know they worry about this, but we have to worry a lot about actually our risk reduction. The number one public health problem we have to tackle is obesity. If we don't do that, Medicare will be too expensive, because the dialysis care, which is why Tom also said it's such a good investment, is going to wipe us out. So dark is bad. We're getting fat, and obesity costs a ton, and it costs. One of the flaws in healthcare is that we don't underwrite actually on BMI. Tobacco, those of you that do public health or do research or are clinicians know, doesn't cost more money until you actually get sick. In fact, people who smoke spend less in healthcare until they're 55 than those who don't smoke, which is a bummer. But we're underwriting on that. So there's a 1.5% or 1.5 times premium increase for smokers. People who are obese, unfortunately, consume a lot more each year and a lot more in the out years. So if we don't change this, we aren't going to make a difference. In healthcare, there's some good first steps, but they're definitely not sufficient. There's menu labeling. There's restrictions on salt. There's more incentives for employers to do wellness programs. There's more premium variation that we give to employers around wellness. But it's a modest first step on a problem that needs a tobacco-like breadth, depth, and intensity of initiatives probably to make a difference. So I just point that out as something that we should also be thinking a lot about as we think about our long-term fiscal health, is that our obesity situation is probably going to have a bigger bearing almost than what ACOs and things happen. So with that, I'm going to pause and invite your questions, and thank you for your comments and for your attention.
Thank you. You appear quite enthusiastic about iPad, but coming from Washington, D.C., you probably know that there are others who are not as enthusiastic about it. I wonder if you could talk a little bit about what you think might be some possible challenges if iPad should move forward. As you know, that there are talks about repealing iPad. I think that one of the challenges that we've been thinking about, I'm from AARP and we're a consumer group, is that we worry about whether iPad has sufficient. As you know, some providers are carved out from iPad, and then there are other elements that are carved out of iPad. And so an iPad, as it's currently written, has targets that they have to meet every 2 years. So we worry about whether or not that might stifle innovations, particularly innovations that could bring down the cost, but might take a while before you realize those cost savings.
Well, as a person that might be one of the potentially unelected members of the IPAB, I'm excited about a jobs program like the IPAB. First of all, the IPAB doesn't do anything if the incentives put in place in healthcare saves money. What I like about the IPAB, and as somebody at the White House who worked hard to have there be an IPAB, is the fact that it's like MedPAC, they're offering up to the minute, or from a policy perspective, up to the minute suggestions on how to adapt the Medicare program to be more productive in ways that don't eliminate benefits and don't harm quality. And so I look at MedPAC and say, gosh, I like probably many of you, read the MedPAC books as if they're interesting, reading. And find a lot of very, very good ideas in the MedPAC books that are never, ever, ever done, that both sides agree on, including all the Medicare Advantage cuts, that can't happen because of the congressional process. And I think there's a whole lot of Medicare policy that if they would have been taken from MedPAC and put into the Medicare program would have put us in a lot better situation today. And so I view the IPAB as a way to help enact good MedPAC ideas that for some reason languish and can't get into law, and that Republican and Democratic policy thinkers, I mean, I was sort of, like Mark and Tom, would concur, would be good policy, but were stifled, like DME competitive bidding, something that, ironically, the Democrats halted, but now we're doing it in this law that Mark had proposed. And so I hope it's the way to bring in some good ideas into Medicare with more political installation that get rid of distortions in basically prices, of which there's a ton of them, and this law didn't begin to go after them all, as opposed to sort of the crude market basket style cuts. The second thing I'd say is there's no reason why technologies that even with a few year investment that create long-term ROI wouldn't come into the market in a market where there's more risk-bearing payment models, which the private insurance guys are absolutely propagating in the market. There's no reason why they wouldn't be adopted, I think, readily with or without the iPad. So I tend to think of it as a desirable but hopefully not needed tool. But I do think there's some sort of mechanism needed such that if we don't have the benefits and there's a cost that we expect, that there's a way to get them, because the economic picture is going to require it. And I'm worried that a BBA 1997 version 2 will lead to a lot more unintended consequences than sort of more surgical, hopefully, policies done on a more regular basis. But it's a fair question, and it's one that there's no great answer to. Between now and 2018, yeah, it's painful that not everything's in and they're sort of neutered in terms of what they can do. So I share that.
You obviously talked about some of the challenges that we have. As a physician I'm a physician leader of a multi-specialty group that has fully functional electronic health records for 12 years. But according to articles that David Blumenthal has co-authored, only 2% of major academic medical centers, 4% of medical practices have fully functional EHRs, and the error notwithstanding, I'm not sure how many physician groups are going to achieve meaningful use in the next couple of years. That said, really I have two questions. One, are we trying to build a 21st century health system on 20th, if not 19th century medical education system and physician structure, provider structure? And two, so that's part one. And part two, I think you addressed it to some extent in your discussion, the antitrust and market power concerns. I'm concerned that we do need to achieve minimum efficient scale in order to leverage provider size to develop the kind of infrastructure we need. Do you think, to the extent that you're familiar with them, do you believe that the FTC DOJ guidelines go far enough? Personally, I don't, in terms of accountable care.
Good questions, both. On health IT meaningful use, my suspicion is that the phase one, the first stage of meaningful use, the bar set so low that we're actually going to get plenty of adoption. Remember, you don't have to adopt right now. You can adopt any time in the next 3 years and call that year one. So you have time to sort of buy and prepare. But every vendor that I've seen in the market is guaranteeing that if you buy their EHR product, that you will meet the step one or phase one meaningful use standards. I was a little bit disappointed by the fact that in the proposed rule that we put out, those of you that follow such esoterica, we had a lot more aggressive quality measures, and we also had specific measures in the rule so that it was tailored to different types of doctors. All that came out of the final rule for meaningful use, such that there's actually very minimal documentation required, and probably no new documentation required relative to what doctors are doing today to satisfy meaningful use, and it's almost at the level of attestation that you get the payment. Now, step two is likely to look a lot like the proposed rule that came out, at least in the preamble of the current rule. It says you should expect that step two will have specific metrics and a lot more outcomes related instead of sort of process measures, which will be harder for sure and require updates to the software, since the software being bought today, A, doesn't know what those are, and B, undoubtedly will need some, isn't designed right now to necessarily capture what's needed. So I think we're going to see, and I think we are seeing, from the $25 billion of rebates going into the market, plenty of adoption, because if you're going to take any of these risk models that most payers are asking doctors to take, you have to have some way to track the patient level accounting that EHR helps you do. So we're seeing a lot of adoption. I think we're going to see meaningful use. We're also seeing a lot of aggregation, and groups like yours already have records, and so you may be growing, but many like you are growing, and so we're going to see a lot more wiring. That said, your question about the medical education system is spot on. It's interesting to me that Duke Medical School, which in America right now takes a whole year of the 4 years and lets the students do research. They don't do any clinical training, so it's a 3-year program in 4 years. In Singapore, they do it in 18 months. And by every outcome measure, whether it's USMLE scores or performance, the students appear to do just as well. There's clearly ways to have more productivity and shortening of the education, which will create a more dynamic labor market with less debt going in. There's also a chance to change the scope of practice such that there's less narrowness. And there's even a chance to do retraining of doctors, which you could imagine a dermatologist asking to become a primary care doctor someday being a crazy America. But there's a lot more liquidity needed in the way in which doctors can practice and change their careers over time in response to the market that I hope happens. This legislation doesn't do one iota to change the way medical education happens. GME and IME and things haven't been meaningfully changed at all. There's a whole lot of complicated constraints for why the medical education system hasn't changed. But I agree with you. It needs to actually modernize and change quite a bit if we're going to have a medical workforce that has the right skills, attributes, and training times to deliver good care. On the FTC DOJ, I'm only a doctor, and so I don't know if they've picked 30 and 50 if they're the right numbers. Obviously we need to have some way in which they can look at competitive behavior in markets and figure out if we're having your anti-competitive or competitive behavior. I hope that they refine and learn that these aren't fixed in stone, because I would say that the things like the Stark laws and the corporate practice of medicine rules and the anti-kickback rules haven't been dynamic enough, and so they led to, I think, unnecessary constraints in some cases and not necessarily more competition. So I hope that this is a rapidly refined sort of approach as opposed to a, etched in stone. And if it is etched, I pray to God it's right, but who knows? I don't know. It's a great question. I've been following very carefully. Oh, the question is, we certainly tax and penalize those who smoke, and we explicitly tax them in healthcare reform by saying they pay 1.5 times more at any age level, up to that. The plans don't have to fully charge it, but up to that at any age band for their healthcare cost, for their healthcare premiums. What about obesity? There's been a lot of state action in Medicaid programs about whether or not you could impose a tax on obesity. There was a fair amount of discussion early in healthcare reform about should there be fast food taxes or other kind of saturated fat or different kinds of food taxes because of the fact that they tend to be regressive and there wasn't much political desire to do it at the federal level, although there's a lot of interest at the state level. There's a lot of Medicaid programs thinking about if you can't penalize other incentives you can give, either to lose weight or to motivate behavior change related to food and exercise. And it's unclear. So HHS hasn't issued waivers yet that allow states to do that. Some state legislatures have debated it but haven't passed laws to do it. I think it's going to be a fascinating area, and I don't know is the answer. That said, a lot has to be done, so I hope that there's a lot of experimentation here. The employers are doing a fair amount. So most employers, and probably many of your employers, are doing health risk assessments and either offering incentives for BMIs that are normal or incentives to reduce your BMI, or at least try, which might have some return. So, good question. One more, and then Ray looks like he's ready to push me off the stage. So.
I'm curious because much of the conversation today at many tables is on the need for interdisciplinary care. And through all of the conversations this morning, I've never heard anything about interdisciplinary care. And IOM just came out with a major report, as you must be aware of, on nursing. It is the largest workforce, 3 million people, and registered nurses in the United States. And the impact that the IOM report has talked largely about the impact that this nursing force can have, particularly in the care of the older adult, particularly in impacting the cost of the Medicare system. But that and the cost and how that is reimbursed, how that care is reimbursed, of course, then becomes another major issue. But I didn't hear any of that addressed, and I just wondered what your thoughts were on it.
Well, it was an unintentional omission. I meant to be implying in the medical home and ACO models and any of the risk models, they're almost all predicated upon actually substituting nurse labor for doctor labor or allied health or non-physician clinician labor, but non-physician labor to help manage populations and do actually the follow-through. And this whole notion about goal attainment and medication adherence and things is usually a non-doctor-led activity, which is very value-creating and very, very necessary. I think there's no question that team-based models of care are going to predominate absolutely in the future because they both work better, patients like them more, and they're cheaper. So those things create a marketplace that ought to accept them, and it's certainly the secret behind the group healths, the Geisingers, the Kaisers. When you get beneath the surface, what you find is that they have better economic incentives for their providers. They always use teams, and they use better IT. And so it's fundamentally part of the answer. Also, nurses can be trained more quickly, they're more cost effective, and they can be retrained quickly. I mean, there's a lot of advantages to non-physician labor and a need for change medical education so it can actually take on some of those attributes. So thank you for your time and attention. I'm impressed by your stamina.